Okay, that's good. Okay, well, like I said, more people will come on as we as the talk starts, but I think we'll start now. We don't have too many weeks to go before exams and you wrapping up your projects and things. So, and there's not too many more topics to cover. But I thought I would talk today about HIV in children and adolescents because we haven't talked too much about HIV this year. We've talked a bit about it, but not I haven't given a teaching session on it. And I think there are some new recommendations on HIV and antiretroviral therapy in children that it's important to sort of try to understand these new recommendations. So I was going to go through them today, the new recommendations, but as we talk about HIV in general in children, and so this is what I want to. If I can move my slides. So by the end of today, we want to learn a bit more about HIV in children and adolescents, especially to understand the types of antiretroviral therapy and antiretroviral resistance, because that's become a big problem, antiretroviral resistance, and to understand why some children may fail treatment and how to recognize this and how to treat it. And that's really coupled with what I just said about WHO bringing out some new recommendations about antiretroviral therapy, and the P&G recommendations have changed in the last couple of years to include new antiretroviral therapy, and these new ARTs are becoming more and more available. I'll say a bit about those things, and also say a bit about chronic morbidities in children and adolescents who are living with HIV. This is really important because if we're going to be looking after children who have HIV, it's more than just the drug therapy. It's more than just antiretroviral therapy. There's a lot of other multi-system things we need to consider when we're looking after such children. So that's a sort of outline of the teaching session today. And I thought we would start with a case. And this is a case of a child who it's a relatively common situation, I would say. This was a boy, a 10-year-old boy who was known to have HIV, and he's a bit similar to many of the children that I think are in many of the hospital wards or present to hospitals. He'd had 2 weeks of cough. He was on antiretroviral therapy. He had 2 weeks of cough. He'd been on ART for 4 years, and he was quite adherent. He was a smart boy, and he had a very attentive father who made sure he took his ART, at least based on what we could ascertain. But he presented with really with a cough for 2 weeks and some other complications that you might think, well, it's just his HIV, but in a child who's been on ART for 4 years, we should be surprised. We should be surprised that such a child would have such clinical findings. He had really severe muscle wasting. He was profoundly wasted in his arms and his legs. He was alert and talkative, and he had no respiratory distress, but he had scattered chest crepitations, quite coarse crepitations throughout both lung fields. He had no effusion. He was really troubled actually by his the lymph nodes he had palpable in his groin, which were tender, and he also had some tenderness over his right shin. And by the time I got to see him, this was a boy in Madang. He had sputum was positive, gene expert positive for TB, and it was rifampicin sensitive. All right, and so we know that he's got tuberculosis. We know that he's got HIV. He's been on antiretroviral therapy for 4 years. And the question is, what else do you want to know? It's very important, the next questions that you ask such a patient. His weight, by the way, was 18.8 kilos, and he was 10 years of age. And so a 10-year-old boy, you would expect would weigh at least 25 kilos, and he was 18.8. 10-year-old should weigh 25 or 30 kilos, shouldn't they? But he was 18.8 kilos. Yeah. The question is, what else do you want to know? And I mean, I won't. If anyone wants to suggest anything, then please do so. But I mean, some important questions are, well, is his father on treatment? I've already said his father was very attentive. He was sitting at his bedside and very, very caring person who was clearly understood the treatment regime the child should have been on and was helping him with it. Well, the father, no, wasn't on treatment. He was known to be HIV negative, as were the two other siblings. And the question is the mother on treatment? Well, yes, she was, and she passed away a month ago. And so Joseph had been admitted to hospital only a couple of weeks after, a month after his mother died. And the question then is, what treatment was she on? Well, she was on the same as Joseph, actually, his name was Joseph. And it was AZT, 3TC, and nevirapine. And the question is, what's wrong with that? Does anyone suggest what does that make you think of? So we see many patients who are on zidovudine, lamivudine, and nevirapine. That's at least up until a couple of years ago was a common antiretroviral therapy regime that we were using. But there's something wrong with it, and it's very important that we understand what's wrong with it.
Resistance to nevirapine.
Yes, that's right. It's very common at the moment now in the last 5 or 10 years for there to be increasing resistance to nevirapine and other non-nucleoside reverse transcriptase inhibitors. So these two, AZT, zidovudine and lamivudine, are both nucleoside reverse transcriptase inhibitors, and nevirapine, in the P, nevirapine or efavirenz, another non-nucleoside reverse transcriptase inhibitors, and there's a lot of resistance to these non-nucleoside reverse transcriptase inhibitors, and that's really what we have to, I suppose, address in most of the patients who are on antiretroviral therapy as to whether or not they are likely to have antiretroviral resistance, right? And so this was I always think we need to make the most of the investigations we've got. It's not possible to measure everything, but we can make the most of the ones we've got. And what I want you to have a look at this boy's full blood count, Joseph's full blood count, and see what you think about that. We've been through these full blood counts a number of times, and I just want you to try to make the most of all the variables that you see on the full blood count. And a good way to do that is simply to just go through each of them. So to start with, his hemoglobin's 8.9 grams per deciliter, and we know that that's low, all right? So he has anemia. It's not very severe, but he has anemia. Secondly, his platelet count is high, and 650,000. So the normal platelet count being up to 400,000, we sometimes describe it as, and 650 is high. So that can make you think of a number of things. For example, it can make you think of a bacterial infection. Sometimes it can make you think of clots or other things. Inflammation can give you a platelet count that's high. All right? His total white cell count is within the normal range for his age. Remember, he was a 10-year-old boy, so that's within the normal range for age. And his neutrophil count, well, it was a bit high. So again, this might go along with the platelet count being high, and you might think, well, perhaps he's got a bacterial infection. And his lymphocyte count was quite low. And sometimes we see that in children who've got viral infections, but there's another situation in which you might see that. And then lastly, his MCV, his mean cell volume, was low as well. And I think that should give us a clue now to what might be going on. So if you were to look at this full blood count, you can describe it just in one sentence. But can anyone have a go at describing the full blood count, what the interpretation of this full blood count could be? Okay, if no one wants to have a go. He has anemia, which could be related to iron deficiency. He has signs of inflammation that might be related to a bacterial infection, like he has a high neutrophil count and a high platelet count. He has lymphopenia, which could be related to a viral infection, or it might be that it's related to his HIV, and that he does not have immune reconstitution. I'll talk about what that means in a minute. And his MCV is low, so he might have iron deficiency. What I want you to be able to do is look at a full blood count and make those sorts of interpretations, because we have full blood counts available to us all the time, and we have to be able to make the most of them. We won't go on about that again today. Okay, remember I said his weight was 18 kilos. Did I say 18 kilos? Yes, I said 18. Yes, sorry, 18 kilos. And remember, he's a 10-year-old boy. And when we have a child who's 10, we often don't have the tools to determine whether the child has severe acute malnutrition or and just what their weight for age charts are not, they usually only go up to 5. So we end up wondering what to do. Well, the best thing to do is to calculate the body mass index, right? In children over the age of 5, then the best index of nutrition, of the best anthropometric is the body mass index. And the body mass index is the child's weight in kilograms divided by the height squared in meters, right? And so this boy's weight was 18.8 kilos and his height was 1.26 meters, all right? And so if you calculate that out, 18.8 divided by 1.26 squared, right? You have to square that. Then that comes to a body mass index of 11.8, which is extremely low. His body mass index was way down here. This looks like a weight for age chart, but it's not. It's a body mass index chart. And you'll see that the weight on the x-axis, the weight the age starts at 5 and goes up to 19 years. So for children, for school-age children and adolescents, we should use the body mass index. And these charts are so very similar to the weight for age chart, and but this is what we should be using for children over the age of 5. Up to 5, of course, used a weight for age chart, but these are the World Health Organization body mass index charts, and you can find them on the Paediatric Society website. It's important that I think in your for example, in your long cases that you present at the end of the year in your exams, then you should be if you get an older child or an adolescent, you should be trying to calculate the body mass index and plot it on a chart. So you can perhaps download those charts from the Paediatric Society website, and you can print some out and start using the body mass index to calculate in older children, not in children under the age of 5, but in older children. So this boy has, he's been taking his ART very well. His father's been giving it to him. He's on a nevirapine-based antiretroviral therapy, and he's severely malnourished, and he's got some evidence of coarse crepitation, so he's got some evidence of chronic lung disease and some evidence of other opportunistic infections, like the severe lymph nodes he had, the tender lymph nodes he had in his groin, and the pain in his shin. All right. And so I wanted to talk a bit about antiretroviral resistance, and because this is a very important problem that we all have to understand. And I just go back to, there's a couple of papers that I might send around. The first one is a paper looking at the antiretroviral resistance patterns in children with HIV infection. This is a systematic review of studies done all around the world, and it found that resistance to non-nucleoside reverse transcriptase inhibitors was very high. In fact, it was up to nearly 50%. Nearly 50%. Of course, in many countries, it's not that high, but that's extraordinarily high of resistance to non-nucleoside reverse transcriptase inhibitors. This was nearly half of all the children in multiple studies. Over 1,000 children had in RTI resistance. The best evidence in Papua New Guinea comes from, and I wanted to mention this study today because I wanted to pay tribute, if you will, to Dr. Evelyn Lavu, Professor Evelyn Lavu, who passed away a few weeks ago. And many of you, I think, knew Professor Evelyn Lavu. She was an extraordinary woman who was a kind and intelligent person who was extraordinarily accomplished. She was a hematologist, a professor of pathology. She'd done a lot of research and studies into anemia and HIV and cancer, and great loss that she's been. But I wanted to highlight today a really important study that Evelyn published back in 2017. And this was the first, could you possibly mute your microphone? This study by Dr. Lavu was the first description of drug resistance to non-nucleoside reverse transcriptase inhibitors from Papua New Guinea, and it showed that somewhere between 15 and 18% of newly diagnosed adults in PNG had NNRTI resistance at the time of diagnosis. So this was what's called pre-treatment drug resistance. And this was a very important study because before this, nobody really knew just how common NNRTI resistance was. And this study has changed the way we give antiretroviral therapy. As you could see, that in some countries it's even higher. In many countries in Africa, it's even higher, but at least 15 to 18% of adults have NNRTI resistance. And I think after this study, it was clear, it was evident that many children on the wards were failing ART because they were still on nevirapine, lamivudine, zidovudine. All right, and on that triple therapy that we'd been using for the previous 15 years, and that's a very important concept to grasp, that therapy is probably going to fail, and the reason why children were failing nevirapine-based therapy as their NNRTI is because of exposure to monotherapy, and the exposure to monotherapy comes during the time of use of nevirapine for prevention of mother-to-child transmission, particularly during that period of time. But among adults, nevirapine resistance has just come for some other reasons as well. There's other reasons why nevirapine is one of the antiretroviral therapy drugs that is most prone to developing resistance. I can explain that if you like. But so I want you to know about the different classes of HIV drugs and a couple of examples of each of them, and then we'll talk about resistance in a bit more detail, and then we'll talk a bit more about the current recommendation of ART, and because it's changed in the last, in fact, even in the last 2 years anyway. Now, you need to know that there are 4 classes of drugs for HIV, and previously there was only 2. When we started treating children with HIV, there was really only 2: the non-nucleoside reverse transcriptase inhibitors and the nucleoside reverse transcriptase inhibitors. And those of you who've managed children with HIV will know that the 2 NNRTIs are nevirapine and efavirenz. They're the 2 most commonly prescribed NNRTIs. The NRTIs, the nucleoside reverse transcriptase inhibitors, there's a number of those, and you'll be familiar with many of them: lamivudine, zidovudine, abacavir, emtricitabine, and tenofovir. They're all nucleoside reverse transcriptase inhibitors, and there's much less resistance to these drugs than there is to nevirapine and efavirenz. Then there's a group of drugs that have been around for quite some time, but only in many countries for relatively recently. So the protease inhibitors. So one is called lopinavir ritonavir, and sometimes that's called Kaletra. Kaletra is the trade name, but let's call it lopinavir ritonavir because that's the proper scientific name. And then there's a new class of drugs that have actually been around since I think 2013. They were first registered for use among adults, but it's actually only since 2018, so the last 2 or 3 years, that these drugs, that integrase strand transfer inhibitors, INSTI, integrase strand transfer inhibitors, and you'll be familiar with some of the names. I think dolutegravir is the commonest used drug, dolutegravir and raltegravir. Raltegravir is a bit less commonly used, but has a role in the management of newborn babies. But dolutegravir is I want you to remember. So NNRTIs, NRTIs, protease inhibitors, and integrase strand transfer inhibitors, and particularly dolutegravir. The recommendations for first-line therapy for children with HIV has changed in the last couple of years, and this is a very good publication also on the Paediatric Society website. It's the new National Treatment Guidelines for HIV. And remember, I said Joseph, the boy I described before, he was on AZT, 3TC, and nevirapine, and those drugs are no longer useful. And the recommended first-line therapy is abacavir, lamivudine, and lopinavir ritonavir. And so using a protease inhibitor as first-line therapy is now recommended as by WHO and in PNG as first-line therapy for children with HIV. I'll get on to the use of dolutegravir in a minute, because there has been a recent recommendation change by WHO as well. Just going back a bit to the drug resistance and the types of drug resistance, well, there's broadly 2 types. One's called acquired drug resistance, where while a person is on antiretroviral therapy, they develop new mutations that occur because of viral replication, despite them being on antiretroviral therapy. And this was particularly a problem with nevirapine. And part of the reason is that nevirapine has a long duration of action. It has a duration of action of several days, whereas the nucleoside reverse transcriptase inhibitors have a relatively short duration of action. And the reason why patients can develop drug resistance, particularly when they're on nevirapine, is if they have a couple of days where they miss their therapy, then they're, after a day, they're no longer on the nucleoside reverse transcriptase inhibitors, but the nevirapine is still within their system. So the virus gets exposed to nevirapine for a longer period of time and can develop drug resistance because it's then nevirapine monotherapy. Don't worry if that's hard to understand, but there is a good reason why more resistance has developed to nevirapine than it has to the nucleoside reverse transcriptase inhibitors. So that's the first type of resistance is acquired drug resistance, and then the other type is called transmitted drug resistance. And it simply means that a person who's got a resistant clone of HIV passes that virus on to somebody else. And that when you're talking about pediatric HIV, there's a bit of a mixture of both in a way, because many of the many children are born with now transmitted drug resistance. The resistant HIV viruses come from their mother or their father, and sometimes because of prevention of mother to child transmission using just nevirapine, or if there's interruptions in the AZT nevirapine prophylaxis, then children get exposed to nevirapine as monotherapy, and they can develop drug-resistant mutations. And so there's a mixture, I think, between acquired and transmitted drug resistance in pediatrics. Regardless of all that, WHO talks about a statistic called pre-treatment drug resistance. And what that means is that if you look at people who have just been diagnosed with HIV and look at their drug resistance patterns, then WHO says that a pre-treatment drug resistant level of more than 10% is very worrying. And if you remember what I showed you about the study that Dr. Evelyn Lavu had done, you remember that the rates of pre-treatment drug resistance among newly diagnosed adults with HIV in PNG in 2017 were somewhere between 15 and 18%. So even at that time, there was very high pre-treatment drug resistance levels. And that in itself is sufficient to change antiretroviral therapy from the non-nucleoside reverse transcriptase inhibitor base to something else, such as protease inhibitor based drugs. As I said, this is what WHO says: a national pre-treatment resistance of more than 10% to an ARV, regardless of what the drug is, should lead to a different first-line regimen. I won't go into the rest of it, except to say that, I mean, some countries have reached a point where they're doing regular surveillance for drug resistance. They do it on dried blood spots as pediatric HIV drug resistance. They will do a dried blood spot on children during early infant diagnosis. They'll find the virus that's there, and they'll do surveillance for drug resistance on all isolates. And this has really led to a lot of information about the drug-resistant clones that exist in children at the time of birth. This is very important, and WHO has brought in new recommendations about point-of-care testing for children who are HIV exposed, such that you don't have to wait for months to get your test back, or days or weeks to get your test back, but children can be started on antiretroviral therapy right away, rather than exposing them to nevirapine. So what are the recommendations now for changing therapy? And because to answer the question of what Joseph should be on, the child I mentioned at the start, we need to decide the recommended second-line treatment. So he was on AZT, 3TC, and nevirapine, when we know that that can't be right, but we've got to think of what the recommended second-line treatment is. And this has, again, changed a little bit, but there's two possibilities. One, it depends on the first-line therapy the child's been on. And so if the first-line therapy was like what Joseph had been on, nevirapine or efavirenz, NNRTI, then there's two possibilities. One is to use a protease inhibitor, so lopinavir, ritonavir, plus the two NRTIs, so abacavir, 3TC, lamivudine, and lopinavir, ritonavir. That would be an okay regime, that's fine. But if you've got a integrase strand transfer inhibitor like dolutegravir, then using that, a regime like abacavir, lamivudine, and dolutegravir is now what WHO recommends. This is the current and major recommendation. The protease inhibitor base is also fine, but many children are being now transferred in most countries to dolutegravir-based therapy. Right. If the patient's already on lopinavir ritonavir as a base therapy and they
Hey,
develop,
Doc, food per day.
I'm sorry, if the patient's already on a protease inhibitor as the base therapy, then WHO recommends going to dolutegravir. So I just want to cover what drug resistance actually means, because there's three different types of drug resistance, and it's important to know some things about it. These days, we're mostly measuring viral failure, and I think we see clinical failure a lot, and we should have a heightened level of awareness of clinical failure. But the measurement currently that's being recommended by WHO and is being increasingly introduced is the evidence of viral failure, and the viral load is measured as the number of copies per mil. And WHO formally recommended that children had to have 2 viral loads that were 3 months apart, and you needed to ensure that the child had good adherence between those measurements at least 6 months after starting a new ART regime. So if you found a child who had a viral load that was more than 1,000, then you would ensure the child was adherent to therapy and then repeat the measurement in 3 months' time. WHO has changed that recommendation a bit now, and I'll explain why that is. We used to measure what's called immunological failure, because if you think about it, the ideal outcome is that the child has a satisfactory number of CD4 cells. And you remember I mentioned that Joseph, the patient I talked about at the start, his total lymphocyte count was only 0.8. And so he would be, one, he's lymphopenic, and two, probably he'd have very, very low CD4 cells because he had clinical and immunological failure. We're not measuring CD4 counts nearly as much these days as what we were. It's really based on viral failure and clinical failure. Now, I think it's important that we have a recognition of clinical failure. And so WHO says this is new or recurrent clinical events. That means like an infection indicating advanced or severe immunodeficiency. So if a child has signs of stage 3 or stage 4, the clinical staging, then after 6 months of treatment, then they have by definition clinical failure, as long as they don't also have TB at the same time, because that can make a child look like they've got stage 3 or stage 4 clinical failure. So I think we should be really, the child I presented at the start, Joseph, he clearly had clinical failure. He had a body mass index that was way below the 3rd centile. He had evidence of some chronic infections, such as his coarse crepitations, and he had other opportunistic infections with the tender lymphadenopathy. So he had clinical failure and lymphopenia, so almost certainly he had immunological failure. And if he had his viral load measured, almost certainly he'd have viral failure as well, which would be likely that he'd have much more than 1,000 copies per mil. You don't have to have all 3 of these because we don't have all those tests, and all you need to do is have one of those to change to second-line therapy. I think that's what's important. You don't need to have all 3. At the moment, WHO are recommending that viral load testing should be done 6 and 12 months after initiation of antiretroviral therapy, and then every 12 months thereafter. And in the last year or so, WHO has recommended instead of the recommendation that lopinavir ritonavir be the first second-line therapy, they're recommending that all children with any signs of unsuppressed viral loads change to dolutegravir-based therapy or a protease inhibitor-based therapy. Lopinavir ritonavir is okay, but WHO is promoting dolutegravir-based therapy for as many children as possible. I'll explain why that is in a moment. So the new guidelines by WHO can be, as I said, either for lopinavir ritonavir plus 2 NRTIs, that's okay, or dolutegravir, the nuclease, the integrase strand inhibitor therapy. And the reason why they're changing is that dolutegravir is much less likely than NRTIs or NNRTIs to develop viral resistance. And so currently what they're saying is that certainly for any child who's over 20 or 25 kilos, then they should be on a dolutegravir-based therapy if it's available. If not, then lopinavir ritonavir is okay. This new recommendation came out in 2018, and it states that if at all possible, if possible, then all children between above 4 weeks of age and at least 3 kilograms should be established as on dolutegravir-based therapy, and irrespective of their current regime. And the reason why this came out is three reasons. One is, I said, dolutegravir has a higher genetic barrier to drug resistance, so it's less likely to develop drug resistance. Two, in 2018, WHO developed a dispersible tablet. So it's actually a child-friendly formulation now of dolutegravir. So instead of having to take an adult tablet, which really wasn't practical, this is a dispersible tablet that can be used. Now, WHO has recommended that viral load, testing not be a precondition of this, that children should, if possible, transition to dolutegravir-based therapy, even if you don't have viral load testing, if they're showing any signs of clinical failure. So what treatment should Joseph be on? Well, ideally, he'd be on tenofovir, lamivudine, and dolutegravir, or he could be on abacavir, lamivudine, or dolutegravir. And if you don't have that, then he could be on a lopinavir ritonavir based therapy. That would be fine, but he should not be on nevirapine based therapy. Okay. I won't talk too much about this today because these days we're not measuring CD4 counts nearly as much, but it's useful to know what the normal CD4 cell, T cell lymphocyte count should be. I've just listed them there. I tried to classify them as being a child who's got normal immune function, right? A normal child who's immunologically adequately, they have immune reconstitution, or a child who's got moderate immune deficiency or severe immune deficiency. And it's useful to know because it's different with different ages. You might have noticed that the normal lymphocyte count changes with age, and so does the CD4 count. And so I'll send this table around and you can have a look at it and keep it for reference. So I think I always have to come back to it and refer to it because it's hard to remember the different ages and what is moderate immune deficiency, what's severe immune deficiency. I was going to just briefly touch on when you start effective antiretroviral therapy, then some things can happen. And one of them is that children can feel a bit sicker than they normally do. And many of the children we see that have who are failing antiretroviral therapy, they're sick enough, aren't they? They're often quite malnourished and they have one or more opportunistic infections. And sometimes when we start them on antiretroviral therapy, they can get worse for a period of time. And that's often their immune response. Their immune system really just reconstituting and starting to activate again. And sometimes the immune system can activate towards bacteria or viruses that the child has in their system. And that's called the immune reconstitution inflammatory syndrome. And it's a condition which usually it can happen at a very low level, and it can just make children feel really tired in the first sort of 4 to 6 weeks after starting effective retroviral therapy. And for that reason, many children decide that they don't want to take their ART, and their parents don't know that this is an expected part of immune reconstitution, that the child will not feel so good. They might have some nausea and vomiting, some fevers or lethargy. They might look a bit more pale. And when we're looking after these children, we always need to decide whether or not the symptoms they're getting are the normal symptoms you'd expect when children are starting on ART, or whether they might reflect something else. And so it's common. I just want to, I guess, impress upon you that it's common to get a bit of duration or some adverse symptoms when children are starting on effective antiretroviral therapy. The immune reconstitution inflammatory syndrome is particularly important for children who have latent TB, and those children can have a flare up of their tuberculosis. And I'm sure you know, sometimes their chest X-ray can get worse. They can develop a miliary pattern on their chest X-ray or pleural effusions because they get a flare up in their, not a flare up in the bacteria, in the tuberculous bacteria, but the immune response to the bacteria. And that leads to these symptoms typically. And it's usually in the first 6 weeks after starting ART. And mostly it gets better after the immune system is fully reconstituted. But there's lots of, besides TB, there are a lot of other infections that can manifest as IRIS, immune reconstitution inflammatory syndrome. It's not all TB. And there are, as I say, there are many other infections. I've seen children with aspergillus that get an inflammatory response, and seen children with reconstituting immune systems get disseminated CMV. And so there's a number of, just think of the other infections that might flare up when you start antiretroviral therapy. Remember, it's not the bacteria or the virus that's flaring up. It's the immune response to that bacteria or virus. So it's not like you need to stop the antiretroviral therapy. In most situations, you don't need to stop it. It's very important that we don't, that we keep it going. And some children who have signs of immune reconstitution inflammatory syndrome with fevers and lymphadenopathy, they need to go on some steroids at the same time. You need to be careful about that, but some children will feel better if they go onto steroids at the same time. Okay, that's all I want to say about IRIS. It doesn't happen to all children. It's relatively uncommon, but if we do see it, it doesn't. Ideally, you push on with ART. Right. I spoke about an older child before, about Joseph, who was 10 years of age. I wanted to present briefly this case because it teaches us something about why children have antiretroviral therapy resistance. And this was a true story, a 5-month-old girl who presented with severe respiratory distress, and she was a HIV exposed child. And again, the question is, that's all that was told on the history, but the question is, what else do you want to know? What else? And she was awaiting her DBS results, her dried blood spot test. She was still awaiting it at 5 months of age. And she'd been on prophylaxis for 5 months. Her mother was giving her the prophylaxis. And she'd been on for 6 weeks, she'd been on AZT and nevirapine. And then from 4 months, and then from then until 4 months of age, she'd been on nevirapine. And I think this illustrates one of the reasons why for the change in the antiretroviral therapy. Can anyone see anything on this chest X-ray that makes you concerned? This was her chest X-ray at 5 months of age. She'd come in with respiratory distress. Can anyone see what's on the chest X-ray? Okay, well, you might say many people would look at the chest X-ray and see that there's a bit of a haziness about the lung fields, a bit of haziness about both lung fields. but you might remark on the fact that it's hazy only in the central part of the lungs, but at the peripheries, it doesn't look hazy at all. So what's going on? Can someone tell me?
Pneumothorax.
Yes, and is it unilateral or bilateral? If you saw this chest X-ray, what would you think about in this particular scenario? Okay, the message I want to, the lesson I want, to convey in a way is that when you see a chest X-ray that looks like this and you see pneumothoraces, then I want you to think of a particular pathogen. And so this was a 5-month-old girl who'd been HIV exposed, who had been awaiting her dried blood spot test, and she'd been on AZT and nevirapine for a prolonged period of time, and just nevirapine monotherapy until 4 months of age, and she develops this what looked like pneumonia. What sort of pneumonia could it be? Maybe people are answering and they're not, that I can't hear. But if you see air leak, this child also, I want you to see, this was another child with the same problem. So this child had presented with severe respiratory distress in infancy, and I hope you can see there the mediastinal air. So this child doesn't have pneumothoraces, but you can see the blackness, the black lines tracking up the neck and into the soft tissues of the face. And so this child has a pneumomediastinum and subcutaneous emphysema. And what the message is, if you see air leak in a child who's got severe respiratory distress, then there's a number of conditions that can do it. You can get it from RSV, from respiratory syncytial virus, or you can get it from, I saw it this week, from a child with adenovirus, but quite commonly you can get it from pneumocystis. And so if you see air leak, then think about pneumocystis. And so this little girl, who had been waiting to get her DBS results and on nevirapine monotherapy for some months, had developed pneumocystis pneumonia. This was a child with pneumocystis pneumonia, and she'd got air leak. And this child also had pneumocystis and had air leak. Sometimes this is another child with pneumocystis pneumonia without air leak, and you can see the fluffy opacities in both lung fields. This is probably the X-ray that most people think of when they think of a patient who's got pneumocystis, sort of bilateral fluffiness in the fluffy opacities in the lung fields. But if you see air leak, that's another clue to pneumocystis. So clearly this child, remember, what should this child be on? Should probably be on a dolutegravir-based therapy. So the therapy being abacavir, lamivudine, and dolutegravir, or a lopinavir-ritonavir-based therapy, such as abacavir, lamivudine, and lopinavir-ritonavir. And that's the message is that should be the first line therapy for this child, because she's been exposed to NNRTIs for too long, for several months. Okay. The prevention of parent-to-child transmission recommendations hasn't changed, and so it's important that we don't think that nevirapine is a bad drug. It's not a bad drug, and neither is AZT. They're still quite effective as for prevention of parent-to-child transmission. And WHO, even in 2021, still are recommending this same regime for the prevention of mother-to-child transmission of HIV, whether high risk or low risk. It's the same. What is recommended in the PNG national guidelines since 2017 or 2018 is the same as what WHO are currently recommending. But what has changed is what treatment the child should be on if they turn out to be HIV positive from that point in time. And that's why we need to be getting more rapid early infant diagnosis, and WHO are recommending now point of care testing for all infants. Okay, that's all I wanted to say about antiretroviral therapy and about resistance. Now, I just wanted to touch on in the last, just at the last point, about some aspects of the chronic management of these patients, and because it's not just about getting the ART right. And I think increasingly, as more children are surviving on effective antiretroviral therapy, then we're starting to see more complications arising, and a greater need to look after these children in a holistic way. And so, and this is an X-ray of a child who has HIV and clearly has some severe chronic lung disease. And the message is that if we get children on effective antiretroviral therapy and get them to be immune reconstituted early in life, then we'll avoid this type of chronic cystic lung disease that seems so common in children with HIV, chronic bronchiectasis and cystic lung disease. There are many types of chronic lung disease in children with HIV, and as I say, the main message is that we should be getting children onto proper first-line antiretroviral therapy. But many children have chronic bronchitis or chronic bronchiectasis, and I think you can manage these patients reasonably well. Often we think there's not much we can do for them, but I actually think there's a lot of things we can do for them, and I've listed some of the aspects of management of children with chronic lung disease here, both HIV related and non-HIV related. I won't go through them, but I think there's a lot of things we can do, and we have to tailor the interventions and the therapies to the particular needs of that child. But there are a lot of things that can be done for these children to make their lives better, their nutrition better, that make them grow more better, and of course give them time to be on effective antiretroviral therapy. As more children are being treated with ART, then in adolescents we're finding more cardiovascular comorbidities, and so children with HIV should have at least once a year. They should have an echocardiograph to look to see what their cardiac function is, and to make sure they're not getting hypertensive cardiomyopathy or hypertrophic cardiomyopathy. They should have an echo and an ECG every year, because these, both from HIV and from the antiretroviral therapy drugs, it's not uncommon to have a hypertrophic cardiomyopathy. Premature atherosclerosis is relatively common, particularly in children on protease inhibitors. And this is one of the reasons why WHO are recommending dolutegravir-based therapy for most children, but to avoid them getting early onset atheroma. But it's just important to recognise that this is a complication of the ART in some patients, lipodystrophy and premature atherosclerosis. There are some renal and metabolic complications, and particularly in patients who are on tenofovir, TDF. If a patient's got renal impairment, they shouldn't be on tenofovir. That's important because tenofovir can induce some glomerular injury, and both injury to the glomerulus and the renal tubules, and it manifests as a proteinuria. So these patients should have their renal function monitored and their urinary protein measured. I said that lipodystrophy or atherosclerosis is a little bit more common in some patients. They get what's a bit like what we call in adults a metabolic syndrome. They can get hypertensive, they can get atheroma, they can get insulin resistance related to the antiretroviral therapy. But again, the newer forms of ART are less likely to do that. This is a child who has HIV, and you can see this child has pretty marked osteopenia. This is a normal femur and a normal knee X-ray, and this child has quite marked osteopenia, and that's also something that's common in children with HIV, and part of that relates to osteopenia that results from poor nutrition, so low calcium intake and vitamin D deficiency. And part of it relates to if children are malnourished, then they don't have the same impact load on their bones. And therefore, the reason why our bones stay healthy is because if we walk around, if we run, then that puts a load on our bones, and then they become strong and they absorb calcium. But if you don't have that, and if you're relatively immobile, then osteopenia will occur. Just like it occurs for children who've got like a spinal cord injury or they've got cerebral palsy, they'll become osteopenic. Some of the drugs, the ART, can accelerate bone loss. So just like it impairs kidney function, tenofovir can also accelerate bone loss, and that provides a fracture risk in these patients. There are neurological complications that we need to be aware of, and again, ART can play a part in that, but it also can be the answer to that. So if a patient's is immune suppressed, then they're much more likely to have poor brain development. They're less likely to have adequate myelination, less likely to have adequate nutrition, and they will their brains often don't grow very well because of either viral replication in the central nervous system, because they're too immune suppressed. And so getting patients onto antiretroviral therapy is really important for their brain development. But also some ART can have neurotoxic effects, and I think that's important that we recognize that as well. So if you've got a child who is well immune reconstituted, their viral load is low and their lymphocyte count is good, but they are getting signs of impaired development, then it might be related to the ART. There's lots of other factors, I think, that play into whether or not how a child's development's going, and these are things that we just need to be aware of. So stigma and discrimination of not being able to go to school, and sometimes these children are responsible for their siblings, or I would say their guardianship is unstable. It's not clear who's looking after them. And for many children with HIV, the lack of early life opportunities to learn is the biggest factor, as well as not being on effective ART. There's a few malignancies that children can get, and I think you're aware of these, Kaposi sarcoma, non-Hodgkin's lymphoma, and certainly there is a risk of cervical cancer from HPV, and HPV is much more common in human papillomavirus is much more common in children who've got in adolescents who've got HIV. But all of these can be reduced by getting children on effective antiretroviral therapy. You might, in many children with HIV who have inadequate antiretroviral therapy, you might see these sort of rashes, and this is molluscum contagiosum, which is quite common in children who are not effectively aren't on effective antiretroviral therapy. And sometimes when they go on to effective antiretroviral therapy, that can lead to part of iris can reactivate this molluscum contagiosum. That will get better as the patient's immune system becomes properly reconstituted. But we do often see this to me, if I saw this in a child who was undernourished, I would think that this was potentially a sign ineffective antiretroviral therapy. Of course, you can many normal children with normal immune systems have some molluscum, and it's not a problem. But if you see it as a widespread disseminated condition, then you worry the child's not got adequate ART therapy. And then related to some antiretroviral therapy can be these side effects. This is Stevens-Johnson syndrome, which sometimes you can see it with nevirapine, especially if those children also get cotrimoxazole as well. I won't talk much more about Stevens-Johnson syndrome, but I think, Dorothy, could you mute your microphone? So I just wanted to go through some of the chronic complications that children who have HIV can have, because we need to understand it's not just about ART, it is about a holistic approach to the management of their complications and helping them live as healthily as possible. I think this paper is very good, and I might send it around too. It's from South Africa, looking at in South Africa, they have very good antiretroviral therapy and they have very good monitoring, and yet they still see these sorts of complications. And I think it's important that we learn from these sorts of experiences. The paper goes through the reasons why children with HIV get these types of complications, and I won't go through them now, but I think it's well worth reading just to understand more about, even when we do ART right, all the other things we have to do as well. Okay. Now, so monitoring of children with HIV, just finally, it is important that we monitor children regularly. So every 6 months, they should have a viral load. And there's lots of other things that we need to do, like teach the child about their own HIV, so that encourages adherence and gives them encouragement that if they take effective antiretroviral therapy, that they will improve. Remember to give them their vaccines and encourage these sorts of things that improve quality of life, like their school participation and their self-esteem and their mental health. Focus on their nutrition and development and the mitigation of these chronic comorbidities, and be always aware that although ART is really effective if we give it properly, that there are some relatively common drug side effects like anemia, like nausea and vomiting, like lipodystrophy, and even pancreatitis. They're not very common, but we see them in many children, and we need to recognise when the things we're seeing are related to the drugs, and then what to do about it. There's some, just finally, I won't go through this, but there are some new recommendations by WHO now about what to do when children are on ART and you want to start TB treatment. And I'll send this table around. It is important because there are new recommendations about how to adjust antiretroviral therapy when TB treatment's being started. I won't go through that now because it's quite complicated, but it depends on what ART the child is on, and a number of other things. Okay. That's all I was going to say today. I think I've said a lot of things, but I've just wanted the important concepts to be grasped about where we are at with antiretroviral therapy. And I'm happy to stop there and take any questions that you might have.